Hey, it's Dr. Gonzo, and you're listening to Dr. Gonzo's Talking Points. Thanks for joining us. Today, I have the really special pleasure of talking to two good friends of mine, Dr. Anita Krueger, who's a heart surgeon at cardiac surgery at Baylor All Saints in Fort Worth, Texas, and another good friend of mine, an interventional cardiologist, Dr. Sukesh Burjonroppa from Fort Worth Heart in Fort Worth, Texas. And today we're going to be talking about pretty much aortic valve stenosis. So guys, thanks for joining me.
Thanks for having us.
Thanks for having us, Gonzo. Appreciate it.
Yeah. So you know, we're today, probably not a lot of people are actually focusing on heart disease. I had the chance of getting interviewed a couple of weeks ago to talk about heart disease in general. And it was just at the brink of everything going on with the COVID-19. So, you know, just for the record, this week has been probably the second week that they've asked everybody to kind of lock down. And, you know, for the public listening, we are all thinking about, you know, those patients that are sick and are going through a terrible time with the COVID-19, as well as their family members and their loved ones. And Anita and Sukesh and myself are at the forefront of it because we typically have to deal with it when it comes to patients that have respiratory failure. And some people are developing cardiac problems now because they're not willing to go out fearing the risk of contracting the COVID-19. And so what I think is going to happen in the very near future is that we're going to be encountering a lot of patients that are having end-stage cardiac pathology or advanced cardiac pathology because now they're less likely to go out and seek medical attention. So, you know, from a personal perspective and a professional perspective, you know, our hearts go out to everybody currently in the U.S. and in the world when it comes to this disease. But let's talk about something that the three of us actually treat quite frequently, and it's aortic valve disease. I thought today we could focus on aortic valve stenosis. So with that being said, let's start by describing to the public, guys, what's the aortic valve? Anita, why don't you take a first crack at it? What's the aortic valve and where is it located?
Yeah, so in the heart, there are 4 valves, and the aortic valve is, it's a tissue that's between the left ventricle, which is your pumping chamber, and the aorta, which is the biggest artery in your body that carries blood out to the rest of the body. So the aortic valve is this one-way check valve that will close after the heart beats to prevent blood from flowing backwards into the heart. So that's usually how I explain it. It's got 3 leaflets. So we call it a tri-leaflet valve. And there's multiple things that can go wrong with it, but that's kind of where it is and what its purpose is.
That's good. Sukesh, can you tell the public what do we see in patients and what do they complain about when people start developing some type of valve pathology? I know that you're going to talk about symptoms, but what's the most common finding or history that we can elucidate of a patient that comes to see us because of aortic valve pathology?
So now, like Anita alluded, you know, the aortic valve, depending on whether it's got 3 leaflets or 2 leaflets, the manifestations of aortic valve disease, especially from a stenosis, which basically is an obstruction of flow through the valve, or regurgitation, where it's a leaky valve, is related to the structure of the valve, which would then correlate with when the disease pathology manifests. So typically when patients, you talk to them or are getting a history, most of the time you get a history that, hey, I've been told I had a murmur in childhood, or something like that, which would come up. But then when you're actually looking at symptoms per se, typically what we're looking at is chest pain or shortness of breath or the patient passing out. Those are the predominant manifestations in patients who have a blockage in the valve, a stenotic valve, whereby the valve leaflets are not opening and closing as they normally should. And typically this is age-related degeneration of the valve leaflets. And when it's bicuspid valve, like I mentioned, which typically is congenital, the onset of these symptoms and manifestations is kind of a bimodal peak, which basically means that it can manifest itself earlier in the second or third decade of life, or again in the fifth or sixth decade of life, usually in the sixth decade of life when they manifested, compared to the senile, degenerative, native three-leaflet aortic valve stenosis, which predominantly what people have in the community. By about 75 years of age, about 1 in 8 patients have either moderate or severe amount of blockage of this valve. So, but those are the predominant symptoms, if you will, and each of those portends a prognostic point, which correlates with outcome, which typically is mortality, with angina, typically relating to chest pain, which a patient has. And once they manifest it with significant aortic stenosis, 50% of them have a bad outcome by 5 years. If they have syncope, meaning passing out, they have 50% of those patients have a bad outcome, mortality by about 3 years. And the worst is shortness of breath. And when they are short of breath, about 50% of them have a bad outcome by about 2 years. Now, not all patients have these symptoms. Some of them typically allude to maybe fatigue, tiredness, and some nondescript symptoms, but one has to be vigilant and careful because a lot of times, Anita would agree, and you would concur as well, Gonzo, that these patients sometimes minimize symptoms, and you have to tease it out at times as to what their level of activity is on a daily basis, because the patients who most benefit from therapeutic, from what we do, either surgical or transcatheter aortic valve replacement for these patients, is probably more related to the symptomatic patients, other than a few other subsets, which we won't get into the weeds. But predominantly, it's those symptomatic patients who would derive the most benefit when we kind of consider replacing the valve.
Okay, let me back up a little bit because you covered a lot of things, and that was really good. So going back to the original assertion that somebody has aortic valve pathology, and we're talking about aortic valve stenosis, you hit it on the head. I think that the majority of patients that have some type of aortic valve pathology, stenosis, or insufficiency, we are talking about aortic valve stenosis at this point, usually present with a history of a murmur. That's a common finding. Would you agree, Anita?
Oh yeah, absolutely.
Now, the problem that always we have as clinicians is that these symptoms, and Sukesh, what is it that we I want to say kindly or nicely call, but what's that those three symptoms, what do they call it, if associated to aortic valve stenosis? It's got an acronym, isn't it? Or it's got a name to it.
Oh, the deadly triad?
The deadly triad. And nobody wants to hear that, but the reality about it is that within the medical community, that's what they call it. The three symptoms associated to aortic valve stenosis is our chest pain, fainting, and shortness of breath. And I will say that I typically talk to patients and describe it in that order when we're talking about aortic valve pathology and aortic valve stenosis, because it gives me at least a frame of work that I then can say, okay, well, the reason I did it in this order was because the best symptom to have, there's a symptom to have, is chest pain. The worst is to have shortness of breath. Okay. So Anita, once we get a patient in, okay, say that Sukesh is or Sukesh or anybody who's actually referred a patient to you that has aortic valve stenosis, what's the typical workup that that a patient goes through to determine whether that murmur, okay, is something to that we need to sort of get worried about or take seriously or figure out a management strategy? So what's the process?
Yeah, so usually, being surgeons, a lot of the time people have had all their good diagnostic workup done by the time they come to see us. And the most important test when it comes to valvular disease is the echocardiogram, so that ultrasound of the heart. So they'll take that probe and roll it over the chest and just kind of really take a look at those valves, and they can get some pretty scientific numbers with that. They're looking for the differences in pressure across the valve. They're looking for the flow across, and just all kinds of fancy things that really help us to see how tight is that tight valve. And so luckily the aortic valve, as far as the four valves go, is pretty straightforward in terms of whether or not the disease exists and how severe it is. So there's a lot of smart people in the American College of Cardiology and the Society of Thoracic Surgeons, and they've set forth these guidelines that we follow to basically tell us how tight is this valve. And that comes from those numbers that we obtain on that echocardiogram.
So let me ask a question. So when you look at an aortic valve, not everybody that has aortic valve stenosis, okay, is measured the same way, right, Sukesh? So is there a grading system that we utilize to sort of determine how bad the aortic valve stenosis is that kind of guides us as to therapies?
Absolutely. I think, the initial way in which we were kind of looking at this was the so-called mild, moderate, and severe aortic stenosis. But as we've moved along with getting a more clear picture of what aortic stenosis is and how the ACC and AHA classifies this, we've moved more towards a systematic way of looking into it and kind of looking at ranges of whether they're asymptomatic versus symptomatic aortic stenosis. And the classification where we look at this is where we say whether they are A or stage A, stage B, stage C, or stage D, with the D1 and D2 are those patients who have severe symptomatic aortic valve stenosis. So
the public, but for the public, Sukesh, I mean, just to try to simplify it and make it a little bit more,
mild, moderate, and severe is what I would say would be a simple way of looking at it. And those patients who are severe, which again, we got to look at the echocardiographic criteria, which Anita alluded to. Some of those are basically numbers which we look at, kind of the velocity of blood flow, the peak velocity of blood flow across the valve, which is one of the echocardiographic parameters, the area of that valve, how big that orifice is, and in addition, what is the mean gradient? That is the amount of resistance that the valve is offering while it's opening and closing. Those are the three main things which we kind of look at to delineate and define whether it's mild, moderate, and severe.
Okay.
And typically at this point of time, it's the patients who have severe aortic stenosis are the ones which we take up for treatment when they're symptomatic.
Okay. And so, all right, so not everybody that has aortic valve stenosis needs therapy. Not everybody needs a catheter put into their groin to look and see if there's a true gradient. Most people we can evaluate in the office setting by simply, number one, we do a history and physical, right? We put we listen to them, we examine them. One of the challenges that I've always found is that when they come in with a complaint of shortness of breath, okay, what it really is causing them the shortness of breath, because there's so many other things that causes shortness of breath in medicine that aortic valve stenosis happens to be one of them. But we, and I've always enjoyed working with you guys because you're very thorough in terms of the workup. So you'll do an entire examination, you will then get an ultrasound and then determine how bad the aortic valve stenosis is. And so I think that that is for the public so that they know is that just because you have a murmur, number one, if you're asymptomatic, like Sukesh said, it doesn't mean that you need anything done. But what do you do with that asymptomatic patient, Anita? Somebody who comes in and they have a murmur, and, you know, you send them to get an echo and they have aortic valve stenosis and they don't have any symptoms. What do you do with that?
Yeah, so it really does depend on those numbers that we get in the echo, because if the numbers that we get in the echo indicate, for example, that somebody's stenosis is what we would call critical, like a super, super tight valve, then those patients, even if they are totally fine, they meet criteria to get something done. And even if they don't, let's say they fall into that severe category, but not quite critical. Quite honestly, Gonzo, I find that a lot of times when I sit and talk to these people, they'll come into my office and say, hey, you know, my cardiologist sent me in to see you, but I really feel fine. I really don't have any trouble. I get along okay. I'm in my house. I'm good. But when we sit and we tease out, like, okay, what are you doing during the day? And they're like, oh, I just sit and watch TV. Okay, well, that's probably the reason why you're not really feeling the symptoms. But I say, if you try to go to Walmart and walk around, or if you go out to get the mail, you know, do you feel any change with that? And then a lot of times people will kind of say, yeah, you know, if I walk around Walmart, I do kind of have to stop and rest sometimes, or you know, or even if I say, if we compare, you know, what you're doing now as compared to what you were doing on a day-to-day basis a year ago, a lot of people will say, yeah, I have had to slow down somewhat because, you know, I thought I was just getting older and I'm a little more tired. But that's actually a pretty valid symptom of valvular disease.
Well, let me ask you.
In general, you know, a lot of times patients do actually have symptoms and they may not really realize it until we start talking about it.
Okay, Sukesh, but let me ask you a question then. So if somebody's truly asymptomatic, are there any tests that we do in terms to try to find out if their heart is actually getting impacted by this? And let me tell the speaker, the listener, so that they can understand what we're talking about. When we talk about aortic valve stenosis, it's almost like looking at a door. And if you look at a door, there is the big wide open door that everybody can walk in and out, and then there's the pet door. When we talk about aortic valve stenosis, what we really are talking about somebody who has, instead of having a wide open door, they've got a pet door, and now that room where people have to get out of, the amount of work to push the same amount of people is so big, right? That's the burden that heart's actually having to take to try to push the blood out of the heart. So what we're talking about is a restricted opening of a door that's exiting the heart, or blood is exiting the heart. But Sukesh, are there any tests in people that are asymptomatic? You look at the echo and you're like, my God, I can't believe that you don't have any symptoms. But are there tests that we do in order to prove that the patient has important aortic valve stenosis or critical aortic valve stenosis that you do either in the office or in the hospital?
Well, absolutely. I think, you know, and as Anita rightly pointed out, I mean, the folks we're dealing with are septa octogenarians who have bad hips, bad knees, are restricted in their motion, not having enough exertional thresholds so that they don't have symptoms. So I think one of the key things with these patients.
Yeah, but let me refocus it. So say that you've got somebody in their 50s, okay? And they've got, by what Anita, on resting echo, right? Because that's the key thing. You do the echo, you're not exercising. But how do you prove that somebody has valve stenosis? Okay.
So a couple of ways, Gonzo. I think the treadmill, a modified Bruce treadmill, would be one of those objective ways to kind of do it. One has to be careful not doing a full-fledged exercise stress test on these patients, and sometimes it might just be making them walk up and down the hallway, just some basic assessment of what the patient does, how symptomatic they get with that. But I think at the end of the day, one being really objective, just doing a modified Bruce protocol, which is one of our standard protocols on the treadmill, which is modified so that the incline isn't that high and the speed isn't as much, that would tease out those truly symptomatic patients. And I mean, it's granted, a lot of times you do see patients who are like 4.5 meters per second jet across a valve, and they're pretty functional. And I think it's important to kind of keep a close eye on them with serial echocardiograms or these kind of objective measures with the treadmill to kind of determine if they're truly symptomatic or if there has been progression. One of the other things which I would point out is on the echo as well, the presence of LV dysfunction in these patients, I think that is the other thing. Although they are generating those pretty significant gradients and they say they don't have symptoms, if you do see that the pumping function is weak, that would mean that these patients have compromise of their LV, in which case it indicates there's some decompensation, in which case it would be indicated to go ahead and fix the valve.
Okay. So that was really good. So one of the ways that we test the hypothesis or the theory that you have aortic valve stenosis in the asymptomatic patient is that you put them on a treadmill. We kindly call it the Bruce modified protocol, but you then do serial echoes while you stress the patient and see whether the gradient or the pressure across the valve goes up. And then the other thing is that we look for ventricular dysfunction or dilatation, right? So if the ventricle gets bigger because it can't push against that blockage, then that gives us an indication that the aortic valve stenosis is real, correct?
Absolutely, yes.
Hey guys, that's all the time that we have right now. I really do want to thank you both for actually being part of the podcast. I'm going to invite you both to participate in the next podcast. I want to touch on and talk about the therapies for aortic valve stenosis, because there's a lot of novel things that are happening in that world, and you guys would be just perfect for that. Gang, if you guys want to listen to some more of the podcast, tune into Ask Dr. Gonzo Anything at the Ask Dr. Gonzo Anything channel on YouTube. If any of you guys would like to reach either Anita or Sukesh, feel free to contact them. Anita Krueger's, Dr. Krueger's telephone number for any appointment is 817-912-8240. And Dr. Sukesh Burjonroppa from Fort Worth Heart could be reached at 817-338-1300. Call and they'll set up some appointments. Guys, thanks again for being part of the Ask Dr. Gonzo Anything podcast, and I look forward to seeing you guys next time.
Thanks so much.
All right, great. Thanks, Gonzo. Thanks for having us.
Bye-bye.
All right.